So hello everyone, my name is Macy and I'm here with Riley and Holly, as Jason had mentioned, and we're going to talk today about opioid stewardship and clinical appropriateness. So here's an outline of our presentation. So we'll start off by talking about opioid stewardship program and giving a background on that. And then we'll go into the purpose and objectives and what we do as students and our role. Then we'll go into the audit information and our data, and then where we hope to take our data in the future. So Riley, Holly, and myself are fourth-year pharmacy students at the U of S. We're on a 2-month clinical rotation with opioid stewardship and antimicrobial stewardship program, working alongside Casey and Kristen at RGH and Pasco Hospital. So the purpose of the opioid stewardship program, they recognize that opioids are a class of drugs that can have detrimental effects to patients when used inappropriately, and it aims at supporting the appropriate prescribing and use of opioids within the hospital. We know you guys are probably well versed in the opioid crisis, so we're just going to touch on where Saskatchewan is currently standing. So this is a chart of the total number of apparent opioid-related deaths in Canada. I've highlighted Saskatchewan in the purple box. So as you can see in 2018, there were 125 deaths recorded. In 2019 and 2020, prior to the COVID-19 pandemic, it looked as though those deaths were trending down in all provinces. However, the pandemic has unfortunately changed this. So on the left, there shows confirmed drug toxicities by place. So as expected, Saskatoon and Regina are at the top of the list for Saskatchewan. Stats Canada states that we will meet or surpass the number of overdose deaths seen at the height of the opioid crisis in 2018. And 2020 may be the highest observed opioid-related death of any year. So this increase in opioid overdose deaths may be related to a couple causes. Illegal drug supply because the supply chains were disrupted due to COVID, less access to supports and services like supervised consumption sites, and using substances to cope with stress, as well as also maybe using substances alone when they would usually use them in a group. So from January 1st to October 26th, 2020, Saskatchewan had 100 confirmed opioid overdose-related deaths, with numbers still rising before the end of the year. So this figure shows the percentage of accidental apparent opioid-related deaths by origin of the opioids directly contributing to the deaths in Saskatchewan from 2018, 2019, and part of 2020. So you can see it just says January to March. So that was prior to the the COVID pandemic. The lightest purple is the pharmaceutical opioids. So over half of all opioid-related deaths are from a pharmaceutical product. That's an opioid manufactured by a pharmaceutical company for medical use. This can be related to actual prescription use of these products or diversion. The second largest line, so the medium shade of purple, right here, are non-pharmaceutical opioids, so those that are illicitly manufactured. So this highlights the importance of controlling our opioid prescribing patterns to help decrease the amount of opioids circulating in the public. I'll now pass it off to Riley to talk about the purpose of the opioid stewardship program audits.
Sorry, we're just presenting off one computer, so we're going to be playing musical chairs here when we switch presenters. But I'll go more into details of the purpose of our opioid audits we've been doing. So these audits are used to objectively collect data on opioid prescribing patterns and use within the Regina General Hospital, as well as the Pasco Hospital. Information is depersonalized, analyzed, and then presented back to healthcare providers, with a goal to provide feedback on the current prescribing and usage patterns within different wards of the 2 hospitals in Regina in order to foster awareness and more appropriate opioid usage. Oh, did I leave my notes? Okay. Thank you. So our role in all this and how we did the audits is we, at the beginning of the day or when we decide to do opioid audits, we print out reports of patients that have used opioids within the hospital in the last 24 hours. We analyze the patient charts to determine patient background information. So this could include reason for admission, reason why they're using opioids, and some of their general background history. We have a pre-designed audit tool that was created by students before us in the summer to collect a standard set of opioid-specific information, which I'll go into, I think, in the next slide here. This data is entered into REDCap, and if you don't know what REDCap is, it's just a resource used to collect information for surveys and stuff like that. And then at 4 and 8 weeks, so midway and at the end of our rotation, we take the data that we compiled and analyze it. And then we do data presentations, like this one. And we've also done data presentations to nurses during their wall walks on the wards. So as I said, this audit was designed over the summer by previous students and implemented in the fall of 2020. So far the audit has been running since about the end of August until now, I guess. The data we're presenting to you today is from the end of August until about mid-November. So the audits collect information such as specific opioid ordered, the route of administration of the opioid. We convert all the opioid dosages to morphine milligram equivalents, or MME, ordered and administrated when we can. We also took note of concurrent CNS depressant orders, so benzodiazepines or gabapentinoids, and we also looked at concurrent non-opioid analgesic orders. So our data today is from RGH, specifically floor 5. We have been collecting data from PASQA as well as floor 3 and floor 6 of RGH, but today we don't have as much conclusive evidence to kind of give a good representation of what's been going on. Our best evidence is from floor 5 right now, so we decided that's what we're going to present on. And this data set included 207 patients from 5A, 5E, and 5F, along with 334 opioid orders. Okay, so let's get into the juicy stuff here, the actual data that we collected. So for our first data point here, we have opioid use 3 months prior to admission. So out of 207 patients ordered opioid therapy on RGH-C5, roughly 73.5% had not used an opioid analgesic 3 months prior to admission. And sorry, there's a little typo, but these patients, sorry, I'm getting confused. So they had not used an opioid 3 months prior to admission, so these patients would be considered opioid naive. And patients who are considered opioid naive are at an increased risk of adverse effects from opioid therapy. So how we determined whether they used opioids within the last 3 months is we took a look at their PIP profile as well as their social history. If their PIP profile indicated opioid use within the last 3 months, they were a yes, or if listed substance use indicated an opioid therapy. There was an unknown category, which was about 10% of the patients, and that was either if PIP wasn't updated fully or it wasn't clear that they had used a prescribed opioid in the last 3 months, or if they were a patient who used intravenous drugs, it wasn't indicated which intravenous drug they used or how long ago they had used an intravenous drug. So the next thing we looked at was the route of delivery of the opioid. Most patients were ordered oral or parenteral opioids, with a number of patients having dual routes of administered opioids. So they had an oral as well as a parenteral route ordered. Now, a key thing with dual route administration is that it does provide a lot of flexibility in opioid use for patients who do require it for pain. So if their status changes that they can no longer use an oral opioid, an IV opioid is on board that they can use. But we also have to take in consideration when there is dual routes of therapy ordered at the same time, that the IV administration is 2 times more potent than the oral administration. And oftentimes, we didn't record how often, but oftentimes we've seen that when there was a dual route of therapy, the same dose was ordered both oral and parenterally. So for example, 2 to 4 milligrams hydromorphone, oral or IV, every 4 hours with no consideration that the parenteral route was 2 times that dose. So that could create an opportunity for harm. The next thing we looked at was opioids actually being used. And we noted that the top 3 were codeine, hydromorphone, and morphine, and they made up roughly 95% of total opioids ordered on floor 5. Codeine was most often included in Tylenol 3s. And then other opioids that were prescribed, that were included in the last 5% of opioids prescribed were buprenorphine, fentanyl, methadone, oxycodone, sufentanil, and tramadol. We also took a look at those top 3 opioids that were ordered, and which ones, and the percentage of use across the 3 wards that we looked at. So all 3 wards showed similar usage of the top 3 opioids, but as you can see, 5F had a little bit of an increase of 96.9% of the top 3. And as we recall, 5F is an orthopedics ward, so it kind of makes sense that they use a higher percentage of opioids, especially post-surgery. And then we broke that down further and looked at the top 3 opioid usage by ward. So while all 3 wards kind of had similar usage of the top 3 opioids, there is a difference in the distribution of their use. So as you can see from the chart, hydromorphone orders were higher than the other 2 options on all 3 of the wards, as indicated right here. So that was definitely the most commonly seen opioid ordered on all 3 of the wards. And as you can see on 5E, they had the most usage of hydromorphone out of the 3 wards. This is kind of preliminary data though, since on 5E we did only collect 33 patients out of or 33 orders out of the 334 orders. But still, these preliminary results still can help us analyze prescription patterns throughout these 3 wards in regards to the 3 different opioids that we looked at. Okay, so I think that's it for me. I'm going to let Holly take over, and she's going to go into more of the data that we collected.
Hi, guys. Okay, so like Riley said, I'm just going to keep talking about some of the data that we collected. So this is the morphine milligram equivalents, or the MME per day orders. And so Macy kind of touched on how we convert all the opioid dosages into morphine milligram equivalents so that we can kind of standardize the dosages that patients are receiving. So as we can see here, it is still broken down by ward, but overwhelmingly on all the wards, most patients are ordered greater than 90 MME per day. So that's greater than 90 milligrams of morphine, and it doesn't just stop at 90. We saw most patients in this range were getting somewhere between 100 and 200 milligram morphine milligram equivalents per day ordered for them, and then kind of not very many in the lower range. So our unknown category is also on this table. So unknown would include dosages of fentanyl or methadone, because those don't have reliable conversion charts to switch back to morphine milligram equivalents, so it's just very difficult to calculate with those 2 drugs. So they may be in there because of that. The other reason that it might be unknown is through PCA, which is your patient-controlled analgesia. So they're able to click that button and they might have a lockout, but it's not a good way for us to actually analyze how much they're using per day, or how much they're ordered per day through that, other than the lockout sort of after however long or after how many clicks. So those are the reasons that we have some unknowns, but the general consensus of this graph is that regardless of the ward, most people are getting orders for opioids at greater than 90 milligrams of morphine per day. So this is important because there's some risks at different dosages. So this graph is from ISMP, and it just kind of shows like there is no safe opioid dose, so harms can happen anywhere. But when you get over 50 milligrams of morphine equivalents per day, you're at a 5 times increased risk of overdose. So most of our patients were above that 50, and then when you get up to above 90, you have a 9 times increased risk, and that's actually where the majority of our patients fall. So most patients are coming in at least a 5 times increased risk, but the vast majority are actually at this 9 time increased risk of overdose or adverse effects. We also have to keep in mind that, as we went over earlier, 73.4% of our patients are coming in opioid naive, and that is the vast majority of patients coming in opioid naive and then also still getting greater than 90 milligrams. So it's kind of important to just watch that those orders are quite high, especially for somebody who's never had an opioid or doesn't have opioid tolerance. So once we had looked at how much they were getting ordered, we wanted to see how much they were actually taking. So again, broken down by ward here, we can see that the numbers are the same. The distribution is the same along the bottom for 50 to 90, greater than 90. But we can see actually the majority of patients are taking less than 50. So even though they're ordered these very high amounts, greater than 90 per day, they're actually taking less than 50 per day. And we analyze this through going through the medication administration records, or the MARs, and then looking at nursing notes and different progress notes just to see, like, is their pain controlled, and are they actually getting these, how much of these opioids they're taking. So while it might look good that, okay, even though we have these high orders, we're not giving that amount out, we do have to keep in mind that controlling patient pain is also a goal of therapy when we're using opioids. So if we're not controlling the pain, that can be a bad thing too. However, most of the time we saw through the progress notes and talking to the nurses and seeing the administration sort of over the past couple of days of them being on opioids, that the patients do seem to have well-controlled pain, even at these lower doses than what they're ordered. So there's a lot of room for overdosing, especially if you have a standing order for greater than 90, and the patient continually asks for opioids, even though maybe they don't need as much. There's just huge room for continuing to dose these patients beyond what they might actually need and what is necessary to levels that can be dangerous. So the next thing we looked at was concurrent CNS depressants. So these are increasing risk for CNS depression, obviously, which is a high risk with opioids, especially when we're looking at now we have patients at 5 times greater risk of this or 9 times greater risk and opioid naive. Now they have these concurrent medications. Just can be a whole sort of combination of dangerous things going on there. So depending on the ward, up to 48.5% of patients have concurrent orders for benzos, GABA, or both. So about half the time there they don't have an order, but the other half the time they're getting at least one of those agents. So there is that increased risk of harm there. Now, it's not to say that these agents are bad at all on their own. Lots of times they are used as adjunctive pain medications and can be looked at for alternatives or trying to manage pain at the same time. But we just really have to watch the dosages and was it started in hospital compared to was it continued. A lot of the orders were just continued from community. It wasn't a new start in hospital, so there was maybe some tolerance there, but just watching the sort of concurrent orders is really important, and just knowing how much risk these patients have from the outset. So we did kind of predict that 5A would have had a bit of a higher use of GABA and benzos, possibly because they're the neuro ward, so there's a lot of neurological pain or damage going on there, so we kind of thought that they might have higher use of GABA. Not really shown here yet, but again, 5E has our lowest number of patients, so it's kind of hard to analyze. At this point, these are just our sort of preliminary first assessment of this, but we might notice that that changes through the wards. And that is good to know, because depending what ward you're on and what doctor you're seeing, what indication you have, just knowing that these other things are going on across these wards is really important for keeping patients safe. So the last thing we analyzed was concurrent non-opioid analgesic orders. So this is your Tylenol or Advil orders. so the vast majority of the time, so at least 87.5, but more likely greater than 90% of the time across all 3 wards, there is an order for Tylenol or Advil. So very, very often it is getting ordered, whether it's scheduled or PRN. This doesn't include Tylenol 3, which we included as an opioid because of the codeine content in it. So some patients are taking that and then not taking just regular Tylenol, which is good for avoiding toxicity with too high doses of Tylenol. But just keep a note that this is just plain Tylenol and Advil, but most patients do have an order for that. So the next thing I'm going to talk about is just kind of our thoughts on the data and kind of how we want to go forward. So our last chart there showed whether or not these non-opioid analgesics are ordered, but we have yet to analyze whether or not they're being used. So in terms of future directions, our audit tool that we have now doesn't include whether or not those non-opioids are being used. So we'd like to kind of track that the same way we are tracking the opioid usage, just seeing if this is being optimized or at least tried either prior to or with opioids. So that might decrease their use or decrease the dose that they need. So that's something we want to look into further. So this is our first WebEx presentation since we've been here with you guys. And we have done a couple of wall walks with the nurses, but in terms of future directions, we also want to look at talking to some prescribers, so physicians, residents, medical students, just being able to present our data and show them sort of some of the discrepancies between ordered and used opioids might help to change a little bit of the prescribing patterns within the hospital here. One of the other things we want to do is kind of see if our data and if our presentations are making a difference. So now that we have gone to wall walks and shown these nurses some of our data, it'll be interesting to see if there's a difference in the opioid use and administration, like compared to when we first presented to compared to the next time we see them. So now that they have this information, we do want to see if it is having an effect by changing how much opioids are either being used or prescribed after we've presented the information. We also want to get some more information from Pasqua and the other floors of Regina General. So like we said before, we have looked at them. We do notice a lot of similar patterns. We just don't have enough data from there yet. We spend most of our time at the General Hospital, so that's why most of our data is from here. We're just continuing to get more information. There's no harm in getting more data and just seeing what things are going on throughout Regina, just so we can help foster some stewardship and awareness across the whole of the city and hopefully a little bit further. I know some of you are tuning in from outside of Regina. In terms of practical applications of our data, we want to look at potentially just reorganizing some of these PPOs or these pre-populated orders. So most often, this is a post-surgery, general surgery, post-operative PPO, and this is pretty similar to all the ones that we've seen, whether independent of the reason that they have it. So more often than not, morphine, hydromorph, Tylenol 3, all these things are listed at the top. This one's kind of unique in that Tylenol itself is listed a little bit higher. It's generally not the case. But right off the bat, opioids are the first thing that are listed here. So that kind of puts in prescribers' minds when they're checking things off, like, oh yeah, that's a good first one. Even if we could just rearrange it to have Tylenol or Advil at the beginning, and then maybe notes too that say like, please optimize use or please try prior to initiating opioids, just like simple things that can help, wouldn't take much to rearrange this list, but may help foster some better usage. Other practical applications that we thought about were tracking Narcan usage. So we have seen some patients in hospitals who have had to receive Narcan post-opioid dosing, and just being able to track that, whether or not that changes over time as we do these presentations would be a good objective way to measure whether or not we're helping reduce or prevent harm. And I think, yeah, just continuing to do more of these presentations, that's kind of our hope, to just get the information out there. So I think that's all we have for you guys today. Thank you for listening to our presentation, and if you have any questions, please feel free to ask.
All right, thanks so much, guys. So yeah, if anyone has a question, you can certainly feel free to type it into the chat box down there in the bottom right, or just unmute yourself and ask away. Give a moment here for people to collect their thoughts. I guess while we're waiting for people to think, it's not so much a question, but on your second to last slide there, one of the things that I really like about one of the things that you guys picked up on was that the PPO with the order of the drugs being listed on it for the post-surgical pain management. And it's something, to me, it just strikes a chord with me because it's something that is such a simple fix in terms of, getting people to change their ordering behavior. And it's something that is shown already in the literature. So it's really not even something that we as, the SHA have to study and see if this is something that might help to reduce opioid use as a first line, because it's already known that if you just do something as simple as changing the order of those things in an order set, or like you talked about, giving people the options, here's your NSAIDs or whatever, and optimize this before you choose this next thing, and just putting those things further down in the order set can actually cause some actual behavior change, and therefore potentially more appropriate use of these drugs in patients as well. So I think that's awesome, and that gives us some, considering this is kind of really the first batch of students that have really been able to dive deeper into this data. I think it's great that that's something we can pick out right off the bat. I see Warren has posed a question here. From patients you have seen using Narcan in the ward, did you see any common themes in these patients, like being not opioid naive prior to admission?
I don't think we have enough data really because our audit tool doesn't track Narcan use yet. Just from personal experience, the patients that I saw receiving Narcan a lot of the time were either opioid naive or became palliative. So then they started to receive really high dose opioids fairly quickly once they were determined to be palliative. So then Narcan was kind of needed more often for them. But to give you like a general sort of common theme, I wouldn't be able to at this point, just because it's not data that we have collected. It's just something we want to look into in the future.
A couple of questions. I love to pick students' brains. So first one I wanted to ask you guys is, I love the ingenuity that often comes out of students. And in looking at your data and kind of the work that you guys have done over the past couple of weeks, would you have like one recommendation maybe from each of you about making some general recommendations to prescribers? We do a lot of policy development, right, in hospital, and you guys have probably seen the standard work orders and whatnot. So building a little bit of what Jason said, would you guys have like one recommendation to make, kind of looking at the data that you've crunched and some of the numbers that you've seen?
So I'll start with that. I think an important recommendation to make would be for physicians or prescribers to really differentiate between IV dose or parenteral dose and oral dose. Because oftentimes on MARS, we do see the same dose both parenterally and orally, when in reality, it's not exactly the same dose. And I have seen it being switched from one to the other, with it being the same dose administered, but like we said in our presentation, parenteral doses are 2 times that of oral. And so I think just making sure that differentiation is there would be in the order would be pretty important.
I think to add to that, one recommendation I would make to prescribers is when they're using the PPOs or even when they're writing orders, they do write Tylenol and Advil, but often there is no clarification, like please try first. So that would be still my recommendation, even in written orders, just saying like, please trial Advil or please trial Tylenol prior to giving an opioid. Even if they just tried it one time to see if it decreased pain at all, they might be able to get away with giving a lower dose of opioid after that. So that would be my recommendation.
I think between the 3 of us, we've seen that once. One prescriber said to try and optimize non-opioids before starting an opioid.
Definitely room for improvement.
Yeah, there's definitely room for improvement.
I guess another suggestion I would have is, so with PCA orders, you oftentimes see a concurrent order for Narcan with the PCA, but when a patient is given just an opioid, there is no concurrent order for Narcan. And I understand at the nursing station, they probably do have Suboxone kits and stuff for opioid overdose, but I think just making it more clear that opioid patients, no matter the dose, should have Narcan available would be a good suggestion.
And to go into the PPO I think Brandon talked about this, but I really liked his suggestion in a prior presentation. He just said putting the non-opioids on the first page of the PPO, and then maybe on the back side of the PPO having the opioids, so that you can really, like, as they flip the paper, they have to really, like, think about it, hopefully.
Awesome. I'm so proud of you guys. This is such a great project. I just had one other question for you guys. I know you kind of highlighted it in your slide, but is there any data points that you thought were missing from your project or that you might want to add going forward? One of the things that I just was wondering about in my own head for a data point would be like the number of days that people were actually on opioids. Anything else that you guys thought about for missing data?
Just with the days, based on our data that we're collecting, it's opioids that have been started within the past 24 hours or they've used within the past 24 hours. So it would be really nice to have that, but we aren't catching them right before discharge always, usually more at the beginning. But yes, that's a good recommendation.
I think it would be cool to look into whether or not a day's amount or like a duration was written. And then looking a little bit more into sort of the discharge prescriptions, because then we can maybe make some ties into community. Like, are they writing for a certain amount of days? You know, when they're leaving, how many opioids are they getting? And then also maybe watching like Narcan with that as well, because we said it's a risk no matter what dose they get. So is that being talked about with the patients?
Yeah, that's and those are all very good, and I think that's something too that is something we've been wanting to work towards as far as the opioid stewardship program goes, with looking at, especially with surgical discharges. So what kind of meds people are being given to pick up in community once they've left the hospital after a surgery or something like that, because we know too that's a big piece about whether or not there's appropriate usage going on after they've left the hospital. So that's something else to look at too. One question here in the chat from Leslie P. Have you looked at whether or not the patient was discharged on opioids?
Yeah, I think we just kind of touched on that. We haven't yet, but it would be something that we would like to maybe look at, discharge prescriptions and sort of the differences in them. Yeah. Kind of what I have on that one.
Yeah, I think the tricky part there is just like you said, just catching them when they've been discharged, but before the record goes away, so that we have to pull it out of HIMSS, basically. So, all right. If there are no more questions, then I just would like to thank you guys very much. It was a great presentation. Thanks for sharing your data and spending the last 6 weeks with us. It's been great having you guys here.